this is Dr. Muskaan this side, and I'm presenting a case of COPD. The patient has very classic history of COPD. Let me take you towards the journey of this case. Here is 62-year-old male who has came to ER with chief complaints of shortness of breath since 5 days, fever since 3 days, sputum since 3 days, and fever was also associated with loss of weight and loss of appetite. He is known case of COPD since 5 years. He is diabetic and hypertensive also. He is on irregular medication since 1 year. On arrival, ABC was done. ABC's airway, breathing and circulation. Airway was patent, my dear friends. On breathing assessment, he was tachypneic. SpO2 was 94% on 2 liter oxygen. When circulation assessment was done, he has tachycardia, sensorium was alert, and RBS was 170 mg per dl. I am highlighting this point because patient has a history of type 2 diabetes mellitus since 1 year. He has positive history in respiratory illness. Let me tell you the points of the positive history first. History of seasonal variation is positive because it increases on exposure of cold. History of diurnal variation is positive because it increases in early morning hours. History of dust allergy is positive because a shortness of breath increases when there is exposure to dust. History of steroid is also positive. Now, when I've asked the personal history to the patient, he is a chronic smoker, that is from past 35 years. He has left his smoking 5 years back. He is chronic alcoholic, my dear friends. The history is also from past 35 years. He has left his alcohol 4 years back. He has positive history for tobacco 2 years back. Now, let me tell you his past medical history. He's having history of previous hospitalization in June 2023. His previous reports of 8th June 2023 of echo is, it shows normal left ventricle systolic ejection fraction more than 60%, trace MR and trace TR. MR is mitral regurgitation and TR is tricuspid regurgitation. Reports of 9 June shows gram-positive cocci in pairs. HRCT report shows old infective pulmonary etiology in the background of emphysematous changes. His hemoglobin in June reports was 7.5 gram%. Now on examination, first of all, we say the decubitus. Patient was lying comfortably on the bed. He was oriented to time, place and person, and he was maintaining 93% SpO2 on 2 liter oxygen. Vitals as at present, BP was 144 by 86, pulse rate was 158 per minute, respiratory rate was 40 per minute, and SpO2 was 94% on 1 liter oxygen, and temperature was 96.2 degree Fahrenheit, which was low grade. Severe pallor was present, clubbing, icterus, cyanosis, lymphadenopathy was absent. From all the general examination, I have taken the points that patient is tachycardic, tachypnea is present, low grade fever is present, and severe pallor is present. So 4 points from journal examination. On systemic examination, there was bilateral air entry decreased and bilateral rhonchi was present on in the inframammary region, and bilateral Krebs was also appreciated in interscapular region. Let me take you towards investigation picture of this patient. When I have seen the CBC of this patient, he was anemic, thrombocytopenic, and slightly leukocytosis was present. Hemoglobin was 9.4 gram per dl, platelets was 21,000, and leukocytes was 11,630. When I have seen the KFT reports of the same patient, there was increase in urea and hypochloremia. When I have seen the LFT picture of this patient, there was hypoalbuminemia and increase in alkaline phosphatase level. When I have seen ABG of this patient, there was acute on chronic type 2 respiratory failure because pH was low, PCO2 was increased, bicarbonate was also increased, and PO2 was decreased. So this is the typical picture of type 2 respiratory failure. Further, chest X-ray findings shows consolidation in upper and mid zone of the lungs. There was bottle-shaped heart. This shows the findings of pneumonia, plus the history of pneumonia is also present when I have told you about fever, cough, tachycardia, tachypnea. In USG findings, there was impression of grade 1 fatty liver. HbA1c was 7.9%, and if it is more than 7%, it suggests diabetes mellitus. Blood glucose was 177 gram per dl. His HCV report was also positive, that is hepatitis C virus. Now, I have seen uh, followed that sepsis protocol, that SIR, to sepsis, to severe sepsis, to septic shock. But when I've seen that, when I've seen SIR, he was having hypercarbia, tachycardia, and mild leukocytosis. That means SIR was positive. And when we have to see the sepsis, we see that two of the positive points of SIR plus some infection, and he was having respiratory infection also, with which we have seen from mild leukocytosis. So that means sepsis was also present. Then I have checked out the protocol of severe sepsis, in which we know want 4 points to be positive. So there was sepsis, first point. Second point, we see the signs of end organ damage. We have seen the echo reports, HRCT reports, so that was also positive. Then we need hypotension and lactate levels. Lactate levels was normal at present, but in the June reports it was increased to 4, and hypotension was not there. So the story ends at sepsis here. So from this patient, we have seen that there was a diagnosis of type 2 diabetes mellitus, hypertension, anemia, and COPD. And there might be history of pulmonary cox in future, because the patient has low grade fever, weight loss history, but there was not the present history of night sweats. And I have really enjoyed working on this case, because today I count the differentials of loss of weight, sputum. Let me share it with you. When there is pink frothy sputum, there can be differential of pulmonary edema or ARDS. When there's blood stained sputum, there's differential of hemoptysis. When there is yellow or green color sputum, there's bronchopulmonary infection. When there is rusty or golden yellow sputum, there can be differential of pneumococcal pneumonia. And if there is history of loss of weight, there can be differentials of tuberculosis, hyperthyroidism, heart failure, kidney failure, or Crohn's disease. So that's all. I hope you have also enjoyed listening to the history. So Dr. Muskaan Bansal is signing off now.